Many of you, let's make one thing clear from the beginning. When you register, you're going to get a coupon in your bag. Okay? When you register, that is the coupon that you're supposed to put in that dabba over there. Okay? You see a dabba near the bouquets, the steel telka dabba from Narottam Teli Dabgarwad. So you're supposed to put that coupon in that dabba. During the conference, there will be somebody like at 11 a.m. we had this person who distributed the coupon. So that way there'll be totally 4 coupons. And one is only from the BMW stall. So including the BMW and these 3, you have totally 4. So you're not supposed to put any of them in that dabba. Because if your chitti comes out from that dabba, you will need to have all the 4 coupons. Now if you've already put that coupon there, loot somebody and get one more. Because the 11 baje wali coupon ki ghanti baj gayi hai. So you are only supposed to put the which coupon in the dabba? Registration wali coupon, right? And I request Vinod bhai to stand up with it so everyone can see it. Because a few people have put those Gumti coupons into that dabba. So you've already lost your BMW. Okay, so eventually only I'm going to win it, but you've lost it already. So for your kind information, the coupon in the kit bag is the one you're supposed to put there. Okay? Okay. Beyond that, okay, see, he's already got julm because he's put that in the dabba. So he's already gone. Okay, now we proceed.
So you may afford to forget when are you going to do Cystatin C, but don't afford to forget which coupon is to be placed where. So now we move from the high technique operation theaters to OPDs, and we see some superheroes treat with stethoscopes alone in the OPD. They can convert the critical situations to comfortable positions by their expertise and by compassion in OPD itself. So we have Dr. Vaishali Sulao from Mumbai. She's head of the department and senior consultant of critical care, Fortis Hospital, Delhi. And she says, my speech will speak everything.
So thank you IMA Surat for having me here. And thank you Dr. Vyas also.
Can we have some silence please? Audience please, you have to behave.
I think everyone is now interested in putting the coupon there. The right coupon.
Actually, this is the critical part of the win.
Looks like. Okay, without wasting much time, thank you very much IMA Surat for having me here, and Dr. Vyas also for this kind invitation. My association with Gujarat goes back to 20 years when I did my rural service in a place near Valsad, and I'll come to that a bit later. So I was requested to talk about a few emergencies.
The coupons placed silently will only work.
So I'll divide my talk into 2 parts. First part will be some emergencies which you as physicians will have to deal with in day-to-day basis. And the second half will be in what has progressed in critical care in the last 1 decade, which is resulting in better outcomes in critical care. They may not necessarily something which you would be a part of, but an awareness would definitely be helpful to you as well as to your patients who would come back to you for advice. Because, sorry, this fell down. Because all the patients do go back to their physicians for advice whenever some advanced treatment is advised. So let me. Okay, the first emergency, obviously acute myocardial infarction, and I'll visit this again in the later half of my talk because we have some advancements in the treatment of acute myocardial infarction, but this is a basic physician level. I am a physician myself by background. So Most of the deaths of acute myocardial infarction occur even before they reach the hospital, and you must be reading in the newspaper these days post-COVID or even during COVID, the sudden cardiac deaths and the sudden cardiac arrests have really increased, and the ones which you see in the newspaper is only the tip of the iceberg. The rest is actually not reported, which you and I, we see, in our OPD practices, or we come to hear. Even I've lost a batchmate to a sudden cardiac arrest outside the hospital who couldn't reach the hospital because of traffic in Mumbai. So we all know such sudden cardiac arrests at the age of 40s and 50s, and so we have to be very, very mindful of these silent cardiac illnesses, and be careful about giving them the right treatment even before they reach the appropriate hospital. So good outcomes are seen if thrombolysis is done within 30 minutes or angioplasty is done within 90 minutes. We all know this golden rule. Any delay after the 90 minutes actually exponentially increases the mortality. So if your patient can reach in an angioplasty compatible hospital within 90 minutes, well and good. If not, please thrombolyze the patient. But the best outcome will be if he can reach in a hospital within 90 minutes for an angioplasty. If the patient presents with sudden chest pain in the OPD, take an ECG. All of you must have a portable ECG machine. If it's a ST elevation MI, we all know the mnemonic MONA, morphine. We don't have morphine, I know that, so we can replace it with Fortwin for Nargan. Just to take care of the pain and the anxiety which accompanies such a severe chest pain. Give oxygen 2 to 6 liters per minute, nitroglycerine 0.6 to 0.3 milligrams sublingually, and aspirin 325 chewable. Refer to a hospital immediately which is compatible with an angioplasty. If not, thrombolyze with either of the agents, alteplase, tenecteplase, or streptokinase, whichever is available. If it's a non-STMI, risk stratify the non-STMI, whether it's low risk, high risk, or moderate risk, and I'll show you how to risk stratify. And based on the risk stratification, you have that time interval to refer to, because sometimes relatives also take time to decide where to go, what will be more convenient, and because of financial reasons also, they might take time to decide. So a non-STMI obviously gives you more time, STMI does not. Thrombolytic agents, as I said, the preferred one is of course TPA, but you could give tenecteplase also and streptokinase if the other two are not available. Tenecteplase is the most fibrin specific agent of all these. Contraindications, in the interest of time, I will not go through these. This is the risk stratification. High risk criteria are those with life-threatening arrhythmia or cardiac arrest, mechanical complications like aortic regurgitation or VSD, acute heart failure, pulmonary edema, and recurrent STT changes. Now, moving on to another topic, that is hypertensive emergencies. Sometimes the patient comes to you with a headache, vomiting, and then you measure the blood pressure and it is more than 180 over 120, and that classifies him as acute severe hypertension. Now this acute severe hypertension can be simple acute severe hypertension, malignant hypertension, or hypertension involving end organ damage. And what are those end organs? The end organs are basically pulmonary edema, acute myocardial infarction, acute stroke, aortic dissection, acute kidney injury, and eclampsia. So these are the target organ dysfunctions, and if they present with these target organ dysfunction, then the patient obviously needs hospitalization and management with IV drugs to bring the blood pressure down. I'm not too sure, is this visible? Is this, no, I'm so sorry. So basically, as I said, acute severe hypertension on the left does not have any eye signs. There are no retinal hemorrhages. There is no end organ damage. On the right side, there is either patient has retinal hemorrhage, then that becomes malignant hypertension. If he has end organ damage, then that becomes a hypertensive emergency. So same hypertensive emergency and acute severe hypertension. How do you manage a hypertensive emergency, somebody with end organ damage? Now the drugs available in India are IV labetalol, universal, very easy to administer with very little side effects, unless of course the patient has bradycardia on admission. You can use IV esmolol also, IV nitroglycerine, and IV nitroprusside. Let me not go into the doses. Now depending upon the organs involved, if there is a heart involved, acute myocardial infarction, obviously your choice will be nitroglycerine, because it will cause coronary vasodilatation also and help in the myocardial ischemia. If it is the brain involved, the choice of drug is labetalol, sorry. Oh. The choice of drug is labetalol. As you can see, whether it is acute ischemic stroke, intracerebral bleed, or subarachnoid hemorrhage accompanying acute severe hypertension, the drug of choice is labetalol. Even in preeclampsia, the drug of choice is labetalol. If there is an aortic dissection along with accelerated hypertension, then the drug of choice will be nitroprusside and not labetalol, because usually it is accompanied with bradycardia and you don't want to worsen it. The other emergency that one would come across is status epilepticus. Any epileptic seizure which lasts for more than 5 minutes is called as status epilepticus. You know, when I did my MD, the definition was much longer, and that led to a lot of neurological damage. So now it is 5 minutes. Any seizure persisting for more than 5 minutes is called as status epilepticus. It is divided into a developing one, which is ongoing. Established means more than 5 minutes, it's continuously ongoing. Refractory means it is not responding to your IV lorazepam, IV midazolam, even the IV Levipil which you will be loading. And super refractory means persistent seizures which are going on for 24 hours, which obviously will need it to be treated in the ICU. Now, when the first seizure occurs, the first thing you need to do is give a lateral position so that the patient doesn't aspirate. Do not try to put anything into the mouth. If you can do some suctioning, well and good. Get an IV access if you can. If you don't have the expertise to get an IV access, even an IM midazolam is the drug of choice. Or IV, if you can get an IV, then IV lorazepam is the drug of choice for the seizures, treating the seizures. Obviously, maintain the A, B, and C, airway, breathing, and circulation. Monitor the saturations and also look at the blood pressure. Of course, do not forget to monitor the blood glucose. So in your OPD, you should have a glucometer with strips to monitor look at the hypoglycemia. Now, another anaphylactic shock, and I would like to stress this here because this is something which will not await your referral to any hospital. If someone has come to your hospital, yesterday I ate some shellfish or some prawns for the first time and today I'm getting itching, and while sitting in your OPD, he collapses. Right? So this, you will need to give the adrenaline then and there itself. You cannot wait for some ambulance to come, or you cannot wait for even referral somewhere else. So very essential to identify an anaphylactic shock, basically which will present as respiratory distress or a blood pressure less than 90 mm systolic mercury after an inciting agent. Now, what are those inciting agents? Most commonly food, food like seafood can cause this, even eggs. People are known to be allergic to eggs, and unknowingly sometimes some food material which they have consumed had egg, and then they would land up with anaphylactic shocks. Peanuts, of course, nut allergies. Drugs can also cause, NSAIDs can cause anaphylaxis. We all know that antibiotics can cause anaphylaxis. And then, of course, some other like gloves. We know that even some people can be allergic to the powder used in the glove, powdered gloves. What is the pathogenesis? Basically, the mast cells release on the IgE gets connected to the mast cell, and they release histamine, prostaglandins, leukotrienes, cytokines, and tryptase. All this causes severe vasodilation, bronchoconstriction, that is smooth muscle contraction. When there is smooth muscle contraction, there will be a bronchospasm and severe abdominal pain. So some of them can present with a lot of abdominal cramping also, right? Again, the same airway, breathing, circulation, but please do not delay adrenaline. How much adrenaline to give? 0.3 to 0.5 ml of 1 in 1000. That 1 ampule is 1 ml adrenaline. You give 0.3 IM as soon as possible. Right? Use the thigh to give IM adrenaline. Never use IV in unmonitored situations. Also, never use subcutaneous. The peak action of subcutaneous comes at 28 to 30 minutes, while the peak action of IM comes at around 5 to 8 minutes. So you want rapid action, so use IM adrenaline, give it on the thigh as soon as you have diagnosed anaphylactic shock. Along with that, please give hydrocortisone, and you'll have to continue hydrocortisone for 48 hours because there is a bimodal presentation, and after 36 hours a repeat shock can appear. So please continue the steroid for 48 to 72 hours. H1 receptor blocker, H2 receptor blockers, give some saline and observe for at least 36 to 48 hours so that there is no rebound, because sending the patient home, he might bounce back with a repeat episode of shock. bronchial asthma, standard recommendations which have been going on for the decade, that is use salbutamol plus ipratropium nebulizations every 15 minutes for 3, or you can give continuous if the patient is in severe respiratory distress. Here, one point I'd like to emphasize is subcut adrenaline. I've lost a colleague of asthma while he was in the train because he forgot his EpiPen. So EpiPen, if the patient is intelligent enough, they'll carry themselves, but most of our patients would not. And in your OPD practice, if somebody is going into respiratory arrest because of impending arrest because of acute asthma, you can give subcut adrenaline. So same dose, 0.3 milligrams subcut adrenaline, but it's an extreme solution. Usually beta-2 agonist and hydrocortisone will work in 99% of the cases, but you should know the escape route rather than seeing the patient arrest in front of you. Now coming to the second half of my talk, and this is something just as a part of looking at the journey of critical care. I'm in my 3rd decade of critical care, and a prognosis of certain syndromes 20 years back was pretty hopeless, and we've come a long way since then. So it's exciting times to be in critical care now, just as there are exciting times to be in India now, actually. So I basically did my rural service near Navsari, and those days it was a remote village. To get a bread, I had to go to Bilimora, which was the nearest place where I could get bread. And today when I came on that road, the amazing transformation of that entire road, and it's just, that's where critical care also has gone. Those syndromes like cardiogenic shock, during my training, the mortality was 90%. Hardly we could survive. We didn't even have angioplasty at that time. So what happens to acute myocardial infarction and cardiogenic shock? So this I want to emphasize a lot, because again, we are seeing many young patients with acute myocardial infarctions, cardiogenic shock, and even out-of-hospital cardiac arrest. So out-of-hospital cardiac arrest, the biggest deficiency in this country is no bystander CPR. Bystander CPR must be emphasized. We have to increase our awareness of CPR among general population. If you see the rate of discharge of out-of-hospital cardiac arrest, India versus the West, we are at least 15% behind them in terms of the outcomes, and simply because nobody gives bystander CPRs. Intra-hospital cardiac arrest, the outcomes are at par, but out-of-hospital cardiac arrest, the outcomes are very poor. Now, what is the development in this area? Extracorporeal circulatory supports, ECS, which is called as. We are all aware of IABP, and that is what we have used for the last 20 years. But now we have realized that IABP doesn't work all that well. Mortality doesn't change much. Cardiogenic shock is a mortality of 50 to 60%. But with the ECS now, the mortality has gone down to as low as 30%. It is still high, but it has gone down to half of what. Now, what are these ECS? One is the VA ECMO. We are all aware of ECMO, and I'm sure it's not a new word. It's an extracorporeal membrane oxygenator. But in cardiogenic shock, how it works is, it unloads the heart. You take the blood from, the IVC and the SVC, pass it through the oxygenator, and infuse it into the aorta. So the heart doesn't, if it's not pumping, or it's pumping just 10%, the machine has taken over the heart functions. So this stabilizes the organs. Organ perfusion is maintained. The kidneys perfusion is maintained, the brain perfusion is maintained, the liver perfusion is maintained. Most crucial is to put this in the right window. You cannot put this after all the organs have already suffered ischemia, then obviously the advantage is lost. Another one, which is a new kid on the block, is something called as Impella. Now, every cardiogenic shock who is on 2 inotropes in the United States of America gets an Impella and an angioplasty on the angioplasty table itself. That's become their routine care. It's not possible here in this country. It's extremely costly. One Impella costs 15 lakhs. And so, but it's life-saving in certain cases, and there have been Impella insertions in Mumbai in selected few cases. But an awareness is important that on the angioplasty table, once you have done the PCI and culprit vessel has been angioplastied, one can put an Impella, because the stunned myocardium will give you trouble for the next 72 hours. So what this Impella does is takes the blood from the LV, from the J-tip and pushes it into the aorta. So the heart muscle, if it is weak, it's all right. The machine has taken over and the blood is being pumped into the aorta and organ perfusion is maintained. This is one patient who is on VA ECMO. How does the extracorporeal support help? Well, in few cases, it's bridge to recovery. Many a times, it's a bridge to bridge. That means they will either require LVAD or RVAD or even a BiVAD to tide over the depressed LV functions. Sometimes the LV functions completely improve and you can take the patient off ECMO and discharge the patient without any VADs or any transplant. But sometimes it can be a bridge to heart transplant also, so it's not an easy option to opt for, but in very young patients, 40-year-old patients getting cardiogenic shock coming to you with non-recordable blood pressure, if they can afford, they can go down this pathway if it is available to them within 90 minutes of those symptoms. So liver failure also, we all know critical care, transplantation and advances in hepatology have made, I think there is a special talk on ACLF also today. I am very passionate about liver and I have been sort of involved in liver transplantation also for the last 10 years. Outcomes of acute liver failure, acute and chronic liver failure have improved because of availability of transplant. This is something, another advancement which has made in critical care very exciting, rapid molecular diagnosis, PCR-based diagnosis. So if you get somebody with a viral pneumonia during my MD days, okay, it's viral pneumonia, nothing, comfort care, like symptomatic treatment, not comfort care, symptomatic treatment, they'll get better. And most of the times we would land up writing an antibiotic also. Now if you do a PCR, a swab, and you come to know it is RSV, not even an antibiotic, just symptomatic treatment, the patient, and monitor, of course. If they are elderly, they would need to be hospitalized, but less than 60 years, no need to hospitalize if there is no respiratory failure. So we're getting more and more wiser about these viral pneumonias, which we would never identify earlier because of these rapid PCR-based techniques which are available now for diagnosis. Even in the ICU, blood cultures can be rapidly identified by using what we call as the blood biofire. CSF also, biofire, identifies the culprit very quickly with a very small TAT. Last but not the least, something called as eCPR. Mind you, I'm just introducing this concept. It has, it's a huge Pandora's box. I don't think our country is very ready for this eCPR. What is eCPR? Use of ECMO in CPR. That means if you have a 40-year-old patient, primarily cardiac arrest, who had a chest pain, came to your ER and in front of you crashed and collapsed, and you had to start CPR, and we've had that recently also. Within 10 minutes, if the circulation is not coming back, that is ROSC, return of spontaneous circulation. If you don't have ROSC within 10 minutes, and you know that this is most likely acute myocardial infarction, which is completely treatable, you can start thinking of putting this patient on ECMO. So at 10 minutes, initiate the ECMO call. At 15 minutes, put a peripheral ECMO. At 40 minutes, ECMO should be running. And after this eCPR, after your ECMO is running, wheel the patient into the angiography room, do the culprit angioplasty, and then once the heart has stabilized after 48 hours, you can always wean off the patient of the VA ECMO. This is something called as a eCPR. ISCCM, that is the apex body of critical care medicine, is forming guidelines about eCPR. It's a concept which is just being introduced into Indian ICUs, and it will take at least another 5 years to fine-tune and reach the top of its learning curve. It's not going to be easy. It takes a huge team, coordinated effort, and it takes at least 3-4 specialties to be there. I'm done with it, last slide. To be able to give outcomes. So basically post eCPR, just a few seconds post eCPR, it doesn't mean that 100% are going to recover. Some may not recover. There may be irreversible neurological damage, and in those situations, then we may have to withdraw that VA ECMO also. So patients, we have to educate this patient's relatives in that short span of time, within 10 minutes, that okay, we are going to put ECMO, but don't expect miracles. There will be a situation where if the brain has suffered too much injury, we may have to withdraw the VA ECMO and let the patient die. Sometimes there is full recovery and all the organs may recover, and we can discharge the patient also. This was a request by Dr. Vyas as to what list of emergency equipments and medicines should be advisable for somebody with an office practice. So I've just made a list. Defibrillator, I've put query because it's really not essential unless you have an inpatient facility, and a few drugs which you should have. Please keep adrenaline because you may come across either a status asthmaticus or anaphylactic shock happening right in front of you in your OPD waiting area. Thank you very much. Sorry for exceeding by at least 30-40 seconds. If there are any questions, I'll take it. Otherwise, thank you so much.
We could have a question, just one.
eCPR. So as I said, now let's be very clear. First about CPR, right? The normal CPR which we give, okay? If it is in-hospital CPR, cardiac arrest, then the rate of success, that means discharging the patient with good functional outcome, even in a normal CPR, in the best of the best circumstances, is anywhere between 15 to 20%. If it is out of hospital cardiac arrest, in India, various observational studies have shown that the rate of discharge with a good functional outcome is hardly 6 to 8%. Now, eCPR, we don't have Indian data as such. In the West, they have shown anywhere between 10 to 12%. But only for in-hospital cardiac arrest, let's be very clear. Out of hospital cardiac arrest, eCPR is not an option because they've already spent a lot of time without circulation outside the hospital. So using it when the patient comes to you with no rhythm in the ER is of no use. You'll be wasting at least 2 lakhs because that is the amount of money which the ECMO initiation will require. So as I said, the ideal surrounding is circumstances, 40-year-old man complaining of chest pain, walks into the ER, suddenly crashes in front of you, and you start a CPR. You know this man can be salvaged if you put in a stent within 90 minutes, put in an ECMO in the first 40 minutes, take him to the emergency, to the angiography, put a stent. This will be the best outcomes. There are a lot of selection criteria. There are contraindications for eCPR. The best patient will be a myocardial infarction in a cardiac arrest. I can't go into the depths of contraindications. It's exhaustive. Okay?
Thank you.
Sure. Yes. Yes. So yes, IgE-based testings, yes, for allergens. If history is not clear, then you should send the patient for allergen testings, and that is the IgE-based anaphylactic shock. Definitely you should send for allergy testing, and so that they can avoid those. That's how you come to know about egg allergy. Sometimes the patient doesn't even know that food had egg. Right? So he will not tell you that I had egg yesterday. So how will you know that there is egg allergy? By doing the allergy testing.
Thank you, thank you, thank you.
Thank you so much.
Ma'am, please stay on the stage. My co-host is gushing and rushing to be on the stage with you. And Nidhi, before her announcement arrives, that's the beauty about pathologists. So, ma'am, they're covering you from both the sides. Being a critical care person, keep your ECMO arm ready for one of the punches on the right and one on the left. Okay. Audience, I'm sorry for the ill taste of jokes, and a big round of applause for ma'am. Thank you very much, ladies. Now our next speaker is Dr. Sridhar.